speaker. I'm afraid to pronounce incorrectly. I'm sorry for that. Dr. Shrujan Sasso. Dr.
Sergey in Ukrainian.
Sergey. Sergey Sasso,
In
okay.
Ukrainian.
Sorry, I'm sorry for that. He's a gynecological.
Everyone struggles.
He's a gynecological surgeon at Imperial College and an honorary clinical senior lecturer at the Institution of Reproductive and Developmental Biology, Imperial College, London. Dr. Sasso is a great believer in translational clinical and academical work and projects that have the potential for cross-fertilization between medical and non-medical specialists. And now we are going to listen to the lecture, recognizing and managing physiological cysts and using benign IOTA simple descriptors. Dear doctor, please, the floor is yours.
Thank you very much. First question is, can you hear me? And the second question is, can you see my slides?
Yes, everything is okay.
Perfect. Thank you. Thank you. Good morning, everybody. Delighted to be here with all of you. Thank you very much to both Professor Safonova and Professor Bourne for chairing this, and they invited me to give this talk. This talk and this whole session, as you can see, is about adnexal masses and how to diagnose them, how to triage them, how to decide on management. And the session has been planned out very nicely to take you on a journey of first the terms and definitions, as described by Professor Lil Valentin. So what terms and definitions are we using to describe these masses? And then now we're introducing the concept of diagnostics. And the best, in terms of statistical evidence, a model that has been found out there, that's been described, is of course the two-step model. And Professor Bourne will talk more about that after me. The two-step model is made up of obviously two steps. The first step is the simple descriptors, which I will talk to you about. And then, of course, then comes using the ADNEX algorithm. What I would like to highlight is that for most women, whether they're premenopausal or postmenopausal, so we talk somewhere between 50 to 70, 75%, most of these women, when they have a cyst, that cyst will be physiological or benign. Therefore, pattern recognition and using simple descriptors can very much help you, and it doesn't matter what stage of the journey of ultrasound you are, whether you're at the beginning, intermediate, or expert. I used IOTA, the whole IOTA, to learn about scanning and to learn about the diagnostic of these type of cysts. So please bear that in mind. Benign cysts are the fourth leading cause of gynecological admissions. Most of them, as I said, tend to be physiological or functional, i.e. a normal process of folliculogenesis and the ovulation monthly cycle. Follicular ones are the most common. They tend to be up to 10 centimeters, thin-walled, unilocular, estrogen-dependent, and self-resolving. And when it comes to other types of physiological cysts, the most common ones are corpus luteal cysts, which can be hemorrhagic, not hemorrhagic, peritoneal inclusion cysts, paraovarian cysts, and of course, tubal pathology, abscess, hydrosalpinx, hematosalpinx, salpingitis. So a little bit about each one of those cysts. First of all, a normal follicular cyst, a Graafian follicle, for example, or a follicular cyst that's increased in size following ovulation. You're looking at an anechoic cyst with no solid areas of papulations, a color score of 1, and please pay attention to this rim, this posterior hyperechogenic rim that I'm pointing out here, which is a good sign and secondary to the bounce off of ultrasound going through a fluid with no substance within it and then bouncing off the posterior rim to give you that hyperechogenicity. A corpus luteal cyst, so they do tend to be hemorrhagic, and what you're looking for is this spider web pattern, as you can see on the left-hand side, or a retracted clot, as you can see here on the right-hand side. So again, no solid areas of populations. You see this kind of retracted clot that's come back. So very, very common to see something like this. A paraovarian cyst, this tends to be a cyst adjacent to a healthy normal ovary. Usually paraovarian cysts are very similar to follicular cysts, i.e. anechoic, no solid areas or populations. Please note I'm using IOTA terms and definitions to describe them. Color score of 1, and always adjacent to that ovary. And if you try to poke it with an ultrasound probe, there is no movement of that paraovarian cyst or that lesion separate to the ovary. So they move together in unison. This is another example of paraovarian cyst. Sometimes the ovary can be contained within the paraovarian cyst, as we can see here. So you can see the ovary with a little follicle and endometrioma, and more about that later. And of course, this paraovarian cyst that surrounds it. A very kind of common sight when it comes to dilated fallopian tubes, and you'll see this with patients that may struggle with fertility, is the so-called flapping sail sign. So as any of you that like sailing, Professor Bourne loves sailing, for example, or any of you who live near the sea, you know what I mean by a sail that flaps in the wind. So this hyperechogenic line that you see is very much, you can picture it, suggestive of a tube that's twisted over itself, and a sign of a dilated tube, a hydrosalpinx. And when it comes to other types of tubal pathology, you've got salpingitis, hematosalpinxes, or tubovarian abscesses, when you also this kind of cogwheeling pattern that you're seeing with these little hyperechogenic little dots. So please bear in mind that these follicular cysts, physiological cysts, you don't need to panic, you don't need to stress. Bring these patients back 6 to 8 weeks later, rescan, and a lot of the time they would have resolved. The follicular cysts, the hemorrhagic corpus luteal cysts. Of course, dilated tubes and tubovarian abscesses need to be managed in some capacity, either with antibiotics or surgically if they're fertility patients, in discussion with your fertility specialists. So, moving on to simple descriptors. Now, simple descriptors, as I said earlier, this is part of the two-step model, the best algorithmic model we have when it comes to sensitivity and specificity in diagnosing adnexal masses. And simple descriptors is the first step. Why? Because most of the time, the simple descriptor will give you an easy idea or what's going on, and most of the time will give you the diagnosis. If that doesn't work, you move on to adnex, and more about that later. So, some masses exhibit typical features, which are easy to classify. You do not need to use mathematical models. That's the beauty here. Risk of malignancy index, which is pretty much obsolete now. C1 to 5, unnecessary blood tests, etc. You use simple, easy descriptors, which I will describe to you, and you can apply them to these masses. So all you need is this ultrasound. No need to spend money on, as I said, on blood tests, on MRIs, on CTs, or to do unnecessary surgery, as most of these women will be ovulating and most of these women will be young. So the first one, remember, there are 4. Unilocular, ground glass, premenopausal. That's how you describe this kind of lesion. And these are the descriptors. Unilocular, ground glass, premenopausal, less than 10 centimeters. Remember, for all the descriptors, the 4 lesions we're about to describe, they all have to be less than 10 centimeters. So, very much suggestive, most of you will know this, of an endometrioma. This is what this is trying to describe, and those are the descriptors you are looking for. Unilocular, ground glass, premenopausal. Second type of lesion. Unilocular, mixed echogenicity, acoustic shadowing, and of course, less than 10 centimeters, and again, premenopausal. This, as you can see from the pictures, tends to be very much suggestive of a mature teratoma or a dermoid cyst. Unilocular, mixed echogenicity, acoustic shadowing, premenopausal. The third type of lesion that we have here, again, unilocular, anechoic, regular walls, max diameter lesion less than 10 centimeters. We're talking about a cystadenoma or a serous cystadenoma. So unilocular, regular walls, less than 10 centimeters, premenopausal woman. And finally, the fourth type of lesion, unilocular, again, with regular walls, again, less than 10 centimeters. We're looking at a kind of a scattering, kind of mixed echogenic pattern. The rest, the other type of cyst that cannot be described by the other three lesions. So we're talking about sometimes mucinous or seromucinous cystadenomas. So in summary, we have these simple descriptors. They describe 4 types of lesions, and these lesions are benign. Unilocular tumor with ground glass echogenicity, less than 10 centimeters in a premenopausal woman. Number 2, unilocular tumor with mixed echogenicity and acoustic shadowing, less than 10 centimeters in a premenopausal woman, a mature teratoma. Unilocular anechoic tumor with regular walls, less than 10 centimeters, usually a cystadenoma. And finally, remaining unilocular tumors with regular walls, less than 10 centimeters. Your mucinous cystadenomas, your seromucinous cystadenomas, for example. If these do not apply, you then move on to the second part of the 2-step model, which is the ADNEX algorithm. Why do we like this kind of triaging? Because historically, most of these women would be operated on unnecessarily. So this is not good for when it comes to health economy. We're wasting money, but most importantly, it's not good for the patient. Potential for surgical injury, potential for future adhesions, potential for impacting fertility. The IOTA team, Freeman et al. Publication 2019, looked at the 2-year follow-up of these patients, so who are conservatively followed up, deemed to be benign. And what did they find? That after 2 years of follow-up with no surgery, less than 1% risk of torsion, less than 1% risk of cyst rupture, and less than 1% risk of malignant transformation. So we know now, we have evidence now, we know what to tell these patients when we offer to them what to do. Let's say you have a 6-centimeter cyst, we think it fits in with benign descriptor number 1, it's an endometrioma, you don't feel any other symptoms, we don't need to operate. We can conservatively follow up and see what happens. And we've got the statistics to back us up. So example of a patient, 28 years old, dysmenorrhea and pelvic pain. So you're already thinking on the endometriosis path. The clinical picture is always important. This is how it looks like. So we have a unilocular right-sided ovarian cyst, less than 10 centimeters, ground glass content, color score 1, no ascites, applying benign simple descriptors. I think all of you know which way this goes. It's the number 1. So most likely endometrioma. This patient had surgery because she was in pain and discomfort, and the pathology came back as an endometrioma. So confirming that whole pathway. Briefly, when it comes to triaging these masses, we must highlight the ISUOG IOTA ESGA consensus statement on preoperative diagnosis of ovarian tumors, looking at 4 of the biggest organizations in Europe when it comes to, and internationally, of course, when it comes to both ultrasound diagnostics and surgical management. When it comes to this, what do we have? We have the first step, ultrasound assessment, application of the descriptors, and if it fits in, conservative management with a repeat scan in 6 weeks or discharge. If it doesn't fit in, we use the ADNEX algorithm. And why do we use the ADNEX algorithm? Because it gives us a percentage of the likelihood of this being cancerous, as you can see down here at the bottom. So less than 1%, 1 to 10%, 10 to 50%, and above 50%. And what does this mean? In terms of triaging, we apply the ORAD system, the Ovarian Adnexal Reporting and Data System, split into 5 categories, ORADs 1, 2, 3, 4, and 5. If it's a normal ovary with functional changes, or classic benign lesions of less than 10 centimeters, by using those descriptors, you will classify this as ORADs 1 or ORADs 2. If you're then applying the ADNEX model, if the first step doesn't work, you get a percentage, you can then classify ORADs 3, 4, and 5 according to that percentage. Anything above 50% needs to be managed in a cancer center that's closest to you. Anything below that 50% can be managed in a center, in a unit where there is surgical expertise to deal with it. And that is a quick summary. Of course, the next talk will go more in depth when it comes to ORADs and the two-step model, but especially using that ADNEX algorithm. Thank you.
Thank you very much for this very basic topic, very important, and it's difficult to overestimate the importance of presurgical determination of benign structures with the aim to avoid unnecessary surgery. We have a question in our chat from Simon Meager for you. Thanks for excellent lecture.
Yes.
What is the size you recommend for definition of a simple cyst for the following specific situations? In postmenopausal women, before 3 years and after 3 years postmenopausal. Do you differentiate these categories of women for definition of simple cysts?
So I think when it comes to my practice, size has become a little bit obsolete in some ways. So first of all, there are two things that I care about, and probably similar to what you do. So number one is the clinical picture. Does this patient have symptoms? As you know, patients can have 6, 7, 8, 9, 10, even more, even bigger cysts, and they're completely asymptomatic when it comes to that surgical decision. So are there any symptoms at all? Number two, when it comes to if the patient doesn't have symptoms and she's fine, obviously the next step is to decide whether we need to remove it on oncological grounds. So clinically she's well, but do we need to remove it on oncological grounds? Here, I don't have a size cutoff per se, because we personally apply subjective assessment. So what I think is, what does the cyst look like? Does it look like let's say a serous mucinous cystadenoma that's grown because the patient hasn't been aware of it? So it could be 25 centimeters. She doesn't really feel it, but it looks benign when you apply IOTA terms and definitions. Or for those where it's a little bit tricky, I'm happy to apply the ADNEX algorithm. So size to me isn't relevant unless there is a pain issue. So the pain is clinically not feeling well, or the algorithm that I'm applying points towards an oncological issue with regards to this patient. Historically, size did matter, but with evidence now that's come from the IOTA models, we don't look at it in the same way.
Thank you. And the second part of this question from Simon Meager. What is the size you recommend for definition of a simple cyst for premenopausal women which use oral contraceptive pills? Who use oral contraceptive pills?
If I could just very quickly clarify the question, it's just your leptins quite frequently in a clinical situation where a sonographer does a scan on somebody who's on the pill and they see a leading follicle, let's say it's 27 millimeters. When do you call it a follicle and when do you call it a cyst? And it's in the postmenopausal phase as well. When you're faced with doing a postmenopausal scan, somebody's 54 years of age, 3 years past the menopause, and you find a 2 centimeter fluid-filled cyst. Are you calling it a residual follicle, or are you calling it a cyst where you apply benign descriptors? It's a very common clinical situation, which creates a bit of debate in Australia as to what's the cutoff between something that's a follicle versus something that's a cyst. And it's based on size. Yeah.
I agree with you. I think cyst is a terrible word. In premenopausal women, I usually I'm careful to say follicle if she's ovulating, if it appears benign. I will use the word lesion if there is something to suggest a pathology. I'm very happy to tell her that we don't know whether this is a follicle or a follicular lesion that's grown because of ovulation, or it's pathological. Because, for example, if you have a 45 millimeter anechoic lesion, you can argue it both ways. You can say this is due to follicular genesis, or you can say this is a small serous cystadenoma. And then what I will do is bring the patient back 6 weeks later and usually have the answer. If it's gone, we then know this was a follicular related growth. If it's still there, then you go down the pathological route. But I personally, going back to the first question, I think size is a historic idea. I don't think size is relevant anymore. I think it's more about your subjective impression, or if you think there's a pathology using the two-step model to arrive at a decision, then you mix that with a clinical picture to then decide on future management. I think size is irrelevant in a lot of ways. I don't know whether you agree with this or whether obviously the chairs agree with this, but I think size was more of something that we used to do historically. We used to talk about a 3 centimeter cutoff and 5 centimeter cutoff. I think there's enough evidence now.
I mean, the average diameter of a pre-ovulatory follicle is between 22 and 24 millimeters, and I think the upper range is I think that's what you're referring to, Simon. And the upper range goes up to, you're unlikely to see a normal pre-ovulatory follicle larger than 35. Basically, I think that's pretty well the general upper range. And so I think if one sees a pre-ovulatory follicle around that time of the cycle, which is above that level, I would start to think this is less likely to be a normal follicle. Now, whether she's had a luteinized unruptured, whether that's just, I tend to think if they don't ovulate, they will just get a little bit bigger over time. But I think the consistency in the appearance, you get that sort of little folding, it peeling away of the internal layer. Do you know what I mean? You see that, Simon, and it changes. If you've got a luteinized unruptured follicle, I think that looks slightly different. So I'm not sure it's quite as simple as size, and it changes physiologically as well. I think what you showed in your talk was how you can use ultrasound to look at the physiology. So does that make sense? So you're muted, Simon.
Yeah, that absolutely makes sense. And I agree with you, Tom, the comments you make about seeing luteinization of the high frequency probe. But generally for the broader audience, it's such a common situation to be faced with a fluid-filled space in a woman who is on the oral contraceptive pill or postmenopausal, and whether you call it a cyst or whether you call it a follicle. And it's a gray area that sort of sits outside IOTA in a sense, and is sort of based a little bit on size, but it's gray. And yeah, look, there are different cutoffs, 3.5, 3 centimeters. And it's for the very reason I asked that it's common and it's gray that I asked the question, just to get your take.
In that age group, call it a physiological cyst, and then just ask to rescan. And in a sense, I think, depending on whether there's features that you just touched on around luteinization, etc., I'll say, well, I think we have to wait, because the best test, you talked about it earlier, is have another look sometimes, I think.
Thank you very much.
Vanessa, we're going to have to move on because of time.